Good morning, everyone. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar entitled The What, Why, How, When, and Where of Peer Placement and Integration in MAT with Michael Osborn. The webinar is being made available through a collaboration of the Office of the State Courts Administrator and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and myself by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please again use the chat panel to send any questions you may have as you think of them, and the presenter will address them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. However, I do have the link posted in our chat panel with the event materials that you can print prior to the presentation. The archived video displays what looks like an error message, but it's a delay buffer. Just ignore it, hit play, and enjoy. To access the recording and PowerPoint, you will go to our website, www.fada.org, and our Resource Center Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families and the Office of the State Courts Administrator. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering does remain confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close on midnight on Friday, December the 18th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please include your Florida license number for reporting to CE Broker when you register with our site for the first time. Please note that WebEx does monitor your arrival and departure and provides a report upon completion of the event. It is important that you attend the entire webinar to receive credit. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. Again, we are not permitted to provide partial credit. And with that being said, I'd like to introduce our presenter, Michael Osborn. He started his clinical career as a substance abuse counselor at Operation PAR in 2009, and after completing his Master of Science degree in counseling and psychology at Troy University in 2013, Michael was promoted to clinical supervisor for PAR's Medication Assisted Patient Services Program in Bradenton and Sarasota, Florida. Michael has achieved Florida certifications as a Master Certified Addictions Professional and a Certified E-Therapist through the Florida Certification Board. He began his registered mental health counselor internship in April of 2019 Michael conducts PAR agency trainings and group counseling, e-therapy, gain assessment, verbal de-escalation, and professional ethics. He is also a National Certified Counselor through the National Board of Certified Counselors. Michael is the Clinical Director of Operation PAR's MAPS program with treatment centers in Spring Hill, Port Richey, Clearwater, St. Petersburg, Bradenton, Sarasota, Port Charlotte, and North and South Fort Myers. And Michael, if you're ready to get started, I'll go ahead and pass your slides over to you.
Terrific. Thank you. I appreciate all that. And good morning, everyone. I'm very happy to be here. I'm very humbled about this topic and this presentation. Medication-assisted treatment and the peer or integration are both things that I have direct experience with. So we have a lot to cover today, so I'm going to go ahead and jump right into this. So title of this is the what, why, how, where, and when, and I'm going to work as much as I can to explain all of these and hopefully help you understand. So the course objectives are to describe at least three objectives of the peer position, and this is going to be primarily for the opioid use disorder patients. We're going to understand the purpose of having a peer, explain the dynamics of a peer intervention, and know what the term team approach means in a peer position. So we're going to start with a little background of the opioid epidemic. And if you'll see on the second point, Frontline did a Chasing Heroin documentary that aired on February 23rd of 2016. That is a very good documentary if you want to watch and fully get an understanding of how this all began. I'm going to summarize a little bit of that for you, but just know that there, on the first point, the prescriptions tripled over the 20-year period. One factor behind the surge was a spike in the prescription painkillers. At one point, United States was under-treating pain back in the 60s, and we went from the nation that least prescribed opioid medication to currently the country that prescribes the most. So in 1991, the doctors wrote 76 million prescriptions for opioids, and by 2011, that number nearly tripled. And what happened is the rise was made more dangerous because you have drug cartels that know about these increases of opioids, and they start coming over and introducing their heroin at a much cheaper cost. And when you have people that are spending a lot of money on opioids, sometimes the cheaper heroin is more enticing than the prescription medication. So a statistic I found very eye-opening was that this is from a 2016 statistic. 12 states had more opioid prescriptions than their total population. So you can see the list on the right: Alabama, Tennessee, West Virginia. All of those states had more prescriptions than they did people in their state. So on opioids, these are mainly synthetic opioids. They're the current main driver of drug overdose deaths. I think it's important at this time because there's two terms. There's opiates and there's opioids. And opiates refers to naturally, nature creates these analgesics, the active ingredient. Opium is an example, morphine, codeine. And opioids are an analgesic that at least in part synthesize substances that are not found in nature. So examples of opioids would be OxyContin, Vicodin, fentanyl, methadone, buprenorphine, tramadol. These are opioids. And I kind of mentioned the opiates, and at present, the terminology can be confusing. So opioids include all opioids and opiates. When they use the term opiates, they're referring specifically to the nature created ones. So hopefully that explains those two terms. Opioids were involved, and you see the number there. The overdose deaths, 46,000, and that was 70% of all drug overdose deaths. So 2 out of 3 of these involve the opioids, the synthetic type that I just mentioned. This was made important because if you can see here, it cost society almost $56 billion, and 25.6 was due to lost workplace productivity, and 25 billion was increased in the healthcare cost. And if you'll see, the last sentence talks about a significant portion of this is passed on to employers through insurance costs. So typically when employers have insurance costs raised, the matching from the employees also goes up, so has a big impact there. So what's the cost for hospitals? The emergency department gets overrun, for one. It is set up to handle, obviously, a lot of emergency situations, and when you have a lot of people coming in from opioid overdoses or intoxication or some other serious problem associated with opioid use, takes up a lot of time and resources. You'll also see that due to this opioid abuse, it causes infections, medical conditions, Hep C, the abscesses, and endocarditis. They're making treatment more demanding from the hospital workers. So those hospital costs have been estimated at $2 billion. The endocarditis, I'm not sure if all of you are familiar with that medical condition, but basically it's bacteria in the bloodstream, and it causes serious heart infections. Occasionally this will need heart surgery. It affects the inner layer of the heart. Many persons can be treated with antibiotics, but that's a 4 to 6 week antibiotic intravenous treatment. Operation PAR worked really hard to develop an endocarditis program. And what that was, instead of someone taking up a hospital bed for 4 to 6 weeks, once they stabilized at the hospital within the first week, they came over to Operation PAR and participated in treatment rather than being in a hospital bed and perhaps watching TV. They came over, they got information, they addressed their treatment needs, and on the IV side for the antibiotics, a home health care person came over and treated them. So it was kind of a win-win. It freed up a bed for the hospital, and it got the person treatment that ordinarily would not be getting that treatment. So that's hopefully a little background on endocarditis. We'll go to the next slide, which also talks about the rising hospital admissions. So you can see that overdoses rose 64% in the United States between 2005 and 2014. As the misuse of these ascended, related hospital stay soared from 137 for 100,000 people to 225 for 100,000 people in that decade. So we're going to talk about Narcan or naloxone, which is basically the opioid overdose reversal medication. It is currently what we do at Operation PAR is give every new patient a kit of this. This is really good for family members to have, of persons that are actively using opioids. First responders have this. Police officers in some areas have this. It basically, if you think about a refrigerator with varying strengths of magnets, I'm not sure if your refrigerator is full of pictures like mine is of my grandchildren, but basically there's different strengths of magnets, and opioids have a pretty strong strength of their magnet to the opioid receptor. Naloxone has a very strong, which will knock off that opioid attachment and take it over. So the person goes basically from opioid intoxication to opioid withdrawal. So that's the way it works. It lasts 20 minutes, maybe 30 minutes. If a person has been using quite a bit of opioids, sometimes as the naloxone wears off, the opioids kind of move back into the receptors. So a person being brought back from an overdose, it should not just be give them Narcan and that's it. 911 needs to be called. There may be a chance of needing a second dose of medication of the naloxone, and if you don't have it, that can create problems. Plus, the person should just be brought in for safety precautions. So the medication only works on opioids, so it won't have any effect on a person that has not taken opioids. If you saw a person that was on the ground unconscious and you weren't sure if it was opioids or not, you could administer this naloxone. If it wasn't opioids, it would have no effect on the person. If it was opioids, it would do what I just mentioned and put the person into withdrawal. So, and it does work even if there are other illicit substances present. It can't be used to get high. It has a long safety history. It's pretty easily administered by a layperson, and the routes of administration are intranasal and injected into the thick muscle. Typically, the intranasal is the more popular use of it. And as I mentioned, the person waking up may feel the withdrawal symptoms. Pretty much they will wake up with withdrawal symptoms, and they'll feel confused, anxious, or agitated. Heard reports of some paramedics bringing people back with naloxone, and the person was very agitated. Basically, a very expensive high was erased, and the person was brought back now in withdrawal, and doesn't matter that you just saved his life. He's pretty upset that his expensive buzz was reversed. So there's a lot to consider with when you use Narcan on a person. Okay, so medication-assisted treatment. I'm going to briefly tell a short story, and that is I was not a big fan of medication-assisted treatment. I started at Operation PAR in 2009. My whole understanding and opinion of medication-assisted treatment was when I was 25 years old, and I had a friend whose mother was on medication-assisted treatment, and she had a lot of problems. So I based my whole opinion, thoughts, everything about medication-assisted treatment on one person's experience with it. I also had a brother recover from residential treatment, a 6-month program, and in the back of my mind it was, if anybody wants to recover from substance use disorders, they have to be in a 6-month residential program. So those two things I quickly learned were not true, and based on limited information and just preconceived ideas I had. What I did is I started in 2009, and I quickly saw when I started to receive clients that we have an intake picture of a client that comes in. We take a picture so we can identify them through the front office, and with others knowing who they are. And as I received clients, I brought up their charts, and after 6 days, 7 days, what I was looking at as far as a picture was not what I was looking at in front of me. So basically, there's a lot of benefits in bringing somebody into treatment, getting them stabilized on the medication. So basically, we have 3 different types of medication, which medication-assisted treatment for opioid use disorder is the gold standard. We have methadone, which is the most popular medication. We have buprenorphine, which is starting to gain in popularity, and Vivitrol. I'll go through those. So on the methadone, it's a long-acting medication. When you have somebody addicted to opioids, heroin, basically they're getting high in a very short period of time, and they're coming down in a short period of time, and then they're getting back high again. And this is all assuming they have heroin to use. So if they have heroin to use, basically their day is set up in 2-hour increments of getting high, coming down, getting high, coming down, getting high, coming down. Very hard to function, very hard to hold a job, very hard to take care of children if you're living that kind of lifestyle. So the methadone lasts 24 to 36 hours, and that's for opioid-tolerant individuals. So that's the need for them to come in daily. So 24 hours, they need to be re-administered the methadone so that they can continue to function. And it blocks the euphoric effects of the short-acting narcotics, prevents withdrawal symptoms and drug hunger, and it allows normalization of the disrupted physiology. It does not provide an euphoric rush or high, has no adverse effects on mental capability, intelligence, or employability. It's not sedating or intoxicating at the appropriate dosage, nor does it interfere with ordinary activities, such as operating a car, driving a car, operating machinery. Next slide is a continuation, which talks about that patients can feel pain, experience emotional reactions. The tolerance develops extremely slow over long periods of continued use, and it's not unusual for a patient to be at the same dose for years and years without needing an increase. When it's taken under medical supervision, the long-term maintenance causes no adverse effects to the heart, liver, lungs, kidneys, bones, blood, brain, or other vital organs. Produces very few serious side effects. Some patients experience minor symptoms, but as the methadone dosage is adjusted and stabilized, those usually go away. Sometimes those can be easily treated with over-the-counter medication, but constipation, water retention, drowsiness, skin rash, sweating, and changes in libido are sometimes experienced. So buprenorphine is a partial opioid agonist. There's 2 brand names. Suboxone is buprenorphine with the naloxone. Subutex is just buprenorphine. You might be wondering, we just talked about naloxone being Narcan. Why would that be mixed in with buprenorphine? And the reason that is because if somebody wanted to abuse buprenorphine, they could melt it down and inject it. And if they did that with the naloxone in it, it would put them in withdrawal. So that's a deterrent for people to abuse buprenorphine. The buprenorphine, the Subutex by itself, typically is something that pregnant females will be on, and practitioners can prescribe that as well. So both of those have a long half-life, just like methadone, 24 to 60 hours. It has a ceiling effect, which means that, like methadone, a person who needs to be stable on a higher dose, they get They have 100 milligrams of methadone, it doesn't do it. Basically, they're stable when they're not in withdrawal and they're not sedated. They're kind of in this range where they can function. So methadone person can go higher in their dose until they achieve that stability. With buprenorphine, it's not like that. It's a ceiling effect, which makes it safer. What that means is if someone were to, the maximum dose is 32 milligrams of buprenorphine, and if somebody tried to take more, 40, 48, it would have no more effect than the 32. So for that reason, it has a good safety profile. So both of these medications can be used in the hospital. It's very uncommon for methadone to be used in the hospital, although I know that occasionally it is. On the buprenorphine, this can be used in the emergency department to alleviate those withdrawal symptoms. There is a waiver for physicians, and they get that waiver. They have to take a class, an educational class, and apply for the waiver, and they can be able to treat up to 40 people. So that waiver can be very helpful for physicians instead of being limited by how much buprenorphine they can prescribe. It's also a great tool for transitioning patient to treatment from bridging that gap from the hospital to the treatment. And a patient can begin with buprenorphine and then transition to methadone. Buprenorphine one day, methadone the next day. That can happen. It can't happen the reverse way. Methadone cannot be given one day and the next day buprenorphine. The person will go into withdrawal. So when someone wants to switch from methadone to buprenorphine, they have to wait 2 or 3 days to have that methadone mostly out of their system before they can begin the buprenorphine. And methadone can only be used to treat pain in the hospital. And I think I just mentioned that methadone to buprenorphine without waiting those days isn't good. Well, this is a very important understanding to get on the 3-day rule. I'm going to sum it up for you. The practitioner who's not registered as a narcotic treatment program is not able to prescribe narcotic drugs to relieve acute withdrawal symptoms. But that's the way this is set up. So the 3-day rule allows a prescriber to administer that, and there are certain conditions upon that. So they can administer, but they can't prescribe the drugs. And this is used to get the person for a referral to treatment. So they can't give more than 1 day of medication at one time. They can't do it for more than 72 hours, and there's no renewal. And the purpose of this was to augment, not to circumvent the waiver registration that I mentioned in the previous slide. So we're going to go into Vivitrol and an opiate antagonist. The difference between an agonist and antagonist is an agonist allows something to happen or makes something happen, if you will, and antagonist prevents something from happening. So Vivitrol is an antagonist because it prevents a person from using opioids to feel any effect of those opioids. It also works on alcohol. If a person was to drink alcohol while they were on Vivitrol, it wouldn't work like antabuse and make them sick. It would just prevent them from feeling any of the euphoric effects. The person would still have a blood alcohol level, depending on how much they drank. Their coordination would be off, but they would not feel any of the euphoric effects from the alcohol. So what it does, naltrexone is the drug, and Vivitrol is the extended release form of that. So the naltrexone blocks the opioid receptors in the nervous system. It nullifies those euphoric effects. As I mentioned, it works as well on alcohol. So Vivitrol is an extended release naltrexone. It's injected one time a month. It lasts for 30 days. It's typically injected in the backside, and some program funding may exist to help reduce the cost of Vivitrol. Vivitrol injections are very expensive, over $1,000 from my understanding. So having that funding is pretty common for those that are qualified for it. Federal dollars can pay, and I think state funding is also available for that. So one thing worth mentioning is the naltrexone is available in a daily pill form. It was kind of recommended for people that tapered off of methadone. They have the methadone completely out of their system for, let's say, a week or 10 days, and they could take this once a day naltrexone, and if they were to think about using, it wouldn't have any effect, just as if they were on the extended release Vivitrol, which lasts for 30 days. So that was a good idea and great for people who were motivated to do that, but what you could do is not take the pill on a day, not take the daily pill, and use opioids and get high on the opioids, and then the next day, if you wanted, go back to taking naltrexone. So it could be a back and forth thing, or taken on Friday and then over the weekend somebody could use opioids. So it didn't really lend itself to long-term recovery. You can see if somebody is back and forth in that kind of cycle, wouldn't be too helpful overall. So that's when they created the extended release naltrexone. Once you have it on board, there's no back and forth. You're on it for 30 days. So it can be an effective supplement for those individuals who have tapered off methadone and buprenorphine. Right, next slide. So medication-assisted treatment. This is from SAMHSA. It's important to understand it's not just medication coming in and getting the medication and leaving. There's a lot of components to it. There's counseling, group counseling, there's family education, there's a lot of psychosocial assessments that are done. There's a doctor visit required at admission. There's a yearly doctor annual review of how you're doing. The medications are approved by the Food and Drug Administration, the FDA, and they're individualized treatment. They're driven clinically to meet each patient's needs. Excuse me. So it's a whole patient approach. I can imagine if somebody, a family member, drops off someone to go into the methadone clinic to get their medication, and the person comes out, their thought might be, it's just a matter of going in, getting medication, and coming right back out. And that's really not the case. They come into the front office. They are evaluated typically by the front office personnel. That's not an in-depth evaluation, but just an understanding of how that person is functioning, if they're sedated, and then they go to the nurses to get the medication. The nurses are also evaluating, looking, seeing how the person presents. The nurses are not going to jeopardize their nursing license for somebody who is sedated or, under the influence of something that day. So now we're going to get into peers. So we're going to talk about the use of peers to connect individuals to medication-assisted treatment. One reason I went over all that little bit of background in medication-assisted treatment is so the peer can have an understanding of what that is. A peer without an understanding who might come across an opioid use disorder individual who has gone through something significant who is appropriate for medication-assisted treatment should understand what they're referring the patient to, how it works, what's all involved in the treatment, and also dispelling any myths the person may have about that treatment. So the use of peers, helping individuals connect. As I mentioned, they should be familiar with the medication-assisted treatment program. If they have experience being in, either as a patient or working in that capacity, it's a big advantage. It's some personal experience with seeing how the program works and a better understanding than reading about it or getting some basic information on it. So the peer specialist should understand what the patient requirements and responsibilities are. Typically, programs will have a handbook which covers everything. They go over that in the orientation process. So everything to do with admission to discharge to registering medication to rights and responsibilities and confidentiality, everything is covered in that patient handbook. So the orientation basically is a sit-down session with the counselor and the patient, and they're getting information on all of those. So everything that the patient coming into medication-assisted treatment should know should be understood by the peer. Understanding 65D30, that's a state, has a lot to do with treatment of substance use disorders. I'll go over that in depth in a minute. And if they can't or they don't have experience being in or working in a medication-assisted treatment, and it can be arranged, shadowing a counselor who's working in a medication-assisted treatment would be a really good idea. So, question, why become a peer recovery specialist? I'm going to give maybe just like 30 seconds to think about that, and then we'll talk about some of the reasons. Okay, hopefully I gave you enough time. Some of the possible reasons are listed here. Perhaps the peer would like to help others or give back, be part of the solution, identify with the patient, share their experience, strength, and hope. It might be a calling for the person. The peer, it may enhance or maintain their own recovery, and it might good part of it is to feel a part of something or work as part of a team. The previous slide talked about 65D30, and part of that 65D30.014, we want to get all technical, but that is for the standards for medication-assisted treatment for opioid use disorders. In there, important part of it says that peers can do these services. They can screen, psychosocial assessment, they can do treatment planning, they can do referrals, they can have service, arrange for service coordination, they can do consultations, continuing assessments and treatment plan reviews, they can do recovery support services, crisis intervention, individual, family, and community education, and they can document progress. So there's quite a few things that the peer can do when you're looking at 65D30 and the opioid use disorder section .014. I thought that was really important to emphasize that there are a lot of things that peers can do as far as treatment and as far as services provided to the patient. Okay, moving along. Thought this was a good quote. I actually think it's a great quote. The only way to do great work is to love what you do. I'm fortunate enough to work with two peers in a hospital program, and I can tell by the way they hold themselves, by the way they meet with patients, they really love what they do. They have a passion for it, and the last thing that you'd want is to have somebody who was not so passionate for it, I guess, and treat it just like another job, because it's not another job. It's something very special, and it is a great privilege to work in the capacity of a peer. So we're going to go on to the next slide, which talks about the definition of a peer from SAMHSA. So they're peer support workers. They've been successful in the recovery process. They help others in similar situations. They do this through a shared understanding, respect, empowerment. Peer support workers, help becoming try to stay engaged in the recovery process and reduce the likelihood of relapse. In the next point, it says that they can reach beyond the clinical setting, which is very true. The clinical setting is great. The counselors are well trained, but the peer-to-peer relationship kind of goes more than that clinical setting. There's a little bit more of a understanding and just a connection that is a little bit different, a little bit special, as I mentioned before. And it, hopefully helps peers seek a successful, sustained recovery process. So very important that the clinical part is not just the clinical part. So, excuse me. On the peer support, we have the terms and definitions from SAMHSA. We covered some of it on the last slide, but in the next slide we'll talk about the psychiatric peer interventions. The recovery is a process. Excuse me.
Michael, if we need to take a break, we can do that now.
All the coughing, right?
Would that help you?
I think I can get through it. I think I'm better, but thank you so much, and I'll mention that if it gets to that point.
Okay.
Thank you. So on the recovery process, individuals, they're improving wellness, trying to live self-directed lives, and seeking to reach full potential. That's the term recovery. A peer support group, the voluntarily gathering of people in recovery to provide support. They're sharing knowledge, experience, strategies, offering understanding. Some of the 12-step programs would be included in these support groups. A peer provider is someone who uses those lived experience. I should mention too that a certified peer recovery specialist, when they get their certification, is not only certified in substance use disorders, they're also certified in providing mental health services to address mental illness and work with those individuals. For the purpose of this presentation, I'm kind of keeping it specific to the substance use disorder and their relationship with them, primarily because we're talking about referrals to and integration into the medication-assisted treatment program. So person who uses, back to the peer provider, this can be done in a formal setting, training setting, and they're delivering services to promote that mind-body recovery and resiliency. And peer mentoring, individuals in the later recovery provide that non-professional, non-clinical assistance to individuals in earlier recovery. This can be kind of related to peer supervision. I actually supervise a couple of peers, and it works out well that there's someone that they can talk to. They can kind of run their current experiences with others, their interactions, their thoughts, their feelings with somebody. This can help them achieve long-term recovery. Not that the peers don't have long-term recovery, but it just helps them, give them tools to hopefully pass on to the persons they're working with. So this, I think I've already mentioned, that they're trained and certified to meet with peers for both substance use and mental health conditions. But this is going to be focused primarily on the substance use disorder population. So Florida Certification Board has recovery credentials. Two of the main ones are the Certified Recovery Peer Specialist and then the Certified Recovery Support Specialist. So Recovery Peer Specialist, I'll start with that one on the left. This is a credential. They use their lived experience, that's very important, and their skills in training to help others. So they have this training. It's not as simple as filling out an application. There's many parts to it that need to be completed in the application to become Certified Recovery Peer Specialists. And they're going to help others achieve and maintain their recovery from mental health or substance use conditions. So the credential designates they have competency in the domains of recovery support, advocacy, mentoring, professional responsibilities. This also includes endorsements to demonstrate their certified professionals' lived experience. So we're going to look at those in the next slide. These services that they offer are billable through Medicaid. They're Medicaid billable services. On the other side, we have the Recovery Support Specialist. Little bit difference in this. This credential, people who work side by side with the clinical staff, they may or may not have the lived experience as a person in recovery. That they designate their competency has a little bit different domains, and that is recovery management, practical living skills, social development, resource linkage and follow-up, re-engagement, crisis support, safety, and professional responsibilities. Some of those are interchangeable, but the recovery support specialist isn't, as far as I understand, those services aren't billable by Medicaid, and they're working side by side with clinical staff. Clinical staff member might be running a group, let's say in a treatment program, and a certified recovery support specialist or a peer specialist could also be a member in a group. I've seen this works quite well, where the facilitator talks about a topic, they're a clinical person, they're in a room of people that are having struggles with opioid use disorder or any kind of substance. And as the clinical person presents the topic and begins covering the material, they pass it over to the peer specialist or the support specialist, which gives their take on it in a less intellectual way, through some experience, and typically the others in the group can connect. It not only helps them connect with the material being provided by the clinical person, but it kind of helps them connect and get some understanding from someone who's not a clinical person. So here are the requirements for the CPRS. There's a DCF level 2 background screening. There needs to be lived experience There needs to be some education. A formal education can be a high school diploma, GED, or a higher level of education. They need 40 total hours of content-specific training. There's classes that are set up for that. Typically, those aren't done 2 hours here, 3 hours there. There's usually a week-long program for that specific training. They need 500 hours related to work experience, and they need to have 16 hours of on-the-job supervision. They also need 3 professional letters of recommendation. Then they take the exam, and then each year they need 10 hours of continuing education. I mentioned 2 slides ago about the endorsements of lived experience. So for the peer-to-peer support services, like the Certified Recovery Peer Specialist, applicants must attest, they must have at least one of these endorsements at their time of application. They have to have lived experience as an adult in recovery for a minimum of 2 years. This can be from a mental health condition or from a substance use condition or both. The next one is a lived experience as a family member or caregiver to another person who's living with a mental health and or substance use condition. A veteran with lived experience as a veteran of any branch of the armed forces who is in recovery for a minimum of 2 years from either a mental health or substance use or both. And then the youth endorsement is persons between the age of 18 and 29 when they, at the time of their application, have lived experience as a person who, between the ages of 14 and 25, had a significant life challenge and is now living well with a wellness and or recovery-oriented lifestyle for at least the last 2 years. So those are the endorsements that go along with the credential. And important to understand is that state to state, there may be differences in peer requirements. So the certification from one state might be different than the certification from Florida. So employments may be different because they require specific training and certification and additional things or areas. The state or local, regulations, they dictate the trainings and certifications that are required. And many states have their own certifications, and generally most of these will include peer ethics, the science of addiction, motivational interviewing, and all the pathways to recovery. There are multiple pathways to recovery. And some states reimburse for the peer services. Okay, the physical location peer placement this is pretty easy to understand. It's just the setting of where the peer is to provide their services. Hospitals are a very common place. They also can be in treatment programs where perhaps they're given a separate office to where if somebody needs to speak to a peer that's currently in treatment, they can have the privacy to go in and receive that peer-to-peer, one-on-one support and understanding. Community organizations may have them, halfway houses and other locations may have them. So a meeting between the peers. This is a real-time meeting. It's a discussion between the peer and the person with the recovery needs. And each intervention is unique in that everyone is unique. So you might have a person struggling with, there might be a multitude of different dynamics involved. Somebody just arrived from out of state and is trying to understand the system and is trying to understand what services are available. somebody that has medical issues, somebody that doesn't have medical issues, someone that has family support, someone that doesn't, someone who has experience in a 12-step program. You can see that there's just on and on it can go, different types of situations the peer may have. And with each of those different situations and each of those different persons, the peer specialist has different ways of approaching that person. So as you can tell, it's like a thumbprint, I would say. I don't think there's any two peer-to-peer meetings or interventions that are the same. And that could, and that is another reason why someone might want to get into become a peer specialist. It's just because it's such a unique position, and it's daily, it's always something different. The bottom line, maybe you are helping others, and you are doing it for a number of reasons, but there's nothing better than having a different experience, especially one in this type of position every day. Karina?
Yes.
I think it's a good time to take our 5-minute break. Does that work?
Yeah, that sounds good. So we're going to take a 5-minute break, and if everyone could be back about 1 after 11, that'll give you right at 5 minutes. Thank you. Okay, I'd like to welcome everyone back. Michael, if you're ready, we can get started again.
Okay, thank you very much. I'd like everybody to know I got water and a cough drop, so hopefully this second half won't be interrupted by my coughing. So thanks for putting up with that. But here we go. So I covered the peer-to-peer meeting. And I think the first 30 slides, hopefully that helped you get a good understanding and brought some new information and you got a lot out of it. I think the next 30 slides are really going to go a little bit deeper as far as the integration of peers into the system. So if you're wondering if that isn't going to be talked about in depth too much, I believe you'll be pleased to know that that's coming up with these next slides. So here you see the peer competencies. All of these probably are common sense. Obviously, they have to establish rapport. They have to know that there is no one road to recovery. There's many paths to recovery. They need to know quality roles and tasks. Trauma-informed care is very important. You can imagine that pretty much every person with opioid use disorder or any kind of substance use disorder of any kind of serious nature has more than likely experienced some kind of trauma. There's something called universal precautions. Not sure if you're familiar with that term, but that basically means treat everybody with a substance use disorder as if they had or have some kind of trauma. If you do that, you'll be right 95% of the time, pretty much. So communication is an important part of a peer's role. Cultural competency, different models of treatment and techniques, the dimensions of wellness and the RAP program, ethics and boundaries, working as a team member, doing conflict resolution, and using lived experience. Each of those that I just mentioned will be going into a little bit deeper. So the first one was establishing rapport. I just put on there, hi, Joe, how are you today? Waiting for response. My name is Kyle. Would it be okay with you for us to talk? Important part of that is getting permission from the patient. Things work much better. Maybe the cough drop didn't help. So things typically go much better if you ask permission for the patient to respond or for somebody to take part in something. I used to do nutrition education as a counselor, and I basically would say, we're going to talk about nutrition today. And so I was kind of demanding and setting the tone of what we're going to talk about. And then I learned that saying, would you mind if we talked about nutrition today? And 99 times out of 100, the person would say, yeah, that'd be great. So difference in communication between asking permission and not asking permission. So empathy, honesty, these are all things in establishing rapport, compassion and kindness, having patience, being non-judgmental, being optimistic, being bearer of hope. These are all important components of establishing that rapport. Optimism is really, all of these stand out to me. Non-judgmental and optimism. Typically, you can see, a person can see the optimistic look in another person's eyes. Hard to explain, but if the person believes, if the peer that's suffering believes, that the peer specialist believes that this person can be successful in recovery. That's usually interpreted and accepted and really leads to a successful outcome. Not sure if you followed all that, but if I'm a patient in a hospital and I'm looking at the peer specialist, and the peer specialist is just encouraging me with words and body language that he believes in me, then I will believe that he believes in me, and things typically go much better outcomes. Important. So along with rapport, there's the alliance. This is done using many of the same things we just talked about, but listening, having language, the appropriate language, talking about your shared experience, and using motivational interviewing skills. And we're going to talk about those in a moment. I think I addressed this, but these are some different points that in my research I came across. Weaver and Wilmer in 2015 said that listening to each other in new ways and hearing the story rather than evaluating and assessing the problem is an important part of trauma, understanding trauma. And at times, circumstances will require different approaches and understanding by the peer. That kind of just goes along with it. If I painted a picture that every time a peer meets with a peer patient, it's always going to go well and the person is always going to be receptive, that's not accurate. Many times they're not open to any conversation, and we'll talk about that a little bit later. But don't want you to think that there's this rosy picture of always people being open to communication and interaction with a peer. But communication and with trauma, just like needing to have communication, having a good understanding of cross-cultural communication. The same thing. They need to demonstrate that the appropriate words, their body language, eye contact, physical distance when establishing relationships, and that's talking about people suffering from the effects of trauma, but can be applied with trauma and substance use, or just substance use by itself. So, what you want to do, the peer client who's supporting the peer specialist, who's supporting the peer clients who've experienced some trauma. They need to model resiliency, use those words that promote hope. I talked about optimism and how that is important for a peer client to understand that the peer specialist really communicates that. They want to have courage. They want to say things and kind of have the body language that tells the person that it's a really big step for them to, talk about and be willing to engage in treatment and empowerment. Sometimes that word empowerment can kind of be confusing. I don't know if, might have a boss at work say, I'm going to empower you. I want you to complete this task. With limited resources and limited time, I empower you. And that's not what this is talking about. This is talking about the person to feel empowered. It's a feeling more than a directive. It's feeling like they have what they need to do to reach the goals that they want to reach. And here's another example of asking and how it's best to ask instead of and just assuming or coming at it from a kind of a point of view that is matter-of-factly. You want to ask permission on these. Ask them how to best support them. They are the experts of their life. You may be an expert in peer support services, which I don't doubt once you've been through the training and got your certification, but the patient is the expert on their life and their life experiences. So you want to try to encourage them to join a survivors group, a trauma survivors group. Very important to discuss developing a support network. They can be peer specialists, friends, family members, faith leaders, other professionals, people in recovery. So there's a wide net of persons that someone may include in their support network. So the tasks of a peer are to listen, to encourage, to guide, mentor and coach, help navigate the system. That's very important, navigating the system, because someone may feel ill. Sometimes a peer patient may have a lot of reasons why they can't engage in recovery, and one of them may be negative experiences with trying to get through the system or through some resource that they were unable to get. So being able to help them navigate and get through the system, whether it be financial or housing or treatment, those are very important. You want to help connect those persons to resources, to look at risk and help them explore that, to explore the strengths that they have. Peer tasks are also involve, running groups, having recovery classes. Part of their tasks are to represent peers, keep adequate documentation, and to serve as a supporter. So we kind of went over this at one part. There are multiple pathways to recovery. And there's not just three that are listed here, but there are different groups. So the clinical pathway would be somebody licensed and credentialed professional and a treatment program, whether it be a residential program or a detox program or medication-assisted treatment program. All these different types of programs, they're typically clinical because there's a licensed credentialed professional, either as the director or sometimes providing the services. There's a non-clinical pathway, and this is recovery-based services. Can be a lot of different recovery groups, peer recovery, education recovery, employment, faith. So those are types of non-clinical pathways to recovery. And self-management. Sometimes people have what it takes to go through something significant. Somebody loses their children, somebody overdoses and is found by their child, taken to the hospital, very serious experience. Child is removed, put in DCF. Person gets up in the hospital and says, I'm never going to use again. And by their self-motivation, by their determination, by getting education, they go on and they don't use again. They've used that experience to make recovery possible, and they've done it on their own. Don't see it too often, but I'm sure that it happens. So that's another possible pathway to recovery. So the clinical pathways I just mentioned could be treatment programs. I think I covered all this. And those non-clinical pathways could also include Alcoholics Anonymous, Narcotics Anonymous, Rational Recovery, Celebrate Recovery, secular organizations for sobriety, and Smart Recovery. If you're not familiar with these, there's a lot of good information on search engines if you wanted to look them up. There's also AA and NA central offices in the area. So if someone was working with peer client and they wanted some information, there are numbers to give them and referrals to give them where they can find meetings in their area, get information on it. I'm sure Rational Recovery, Celebrate Recovery, Smart Recovery all have some kind of key point of contact where a person can call and get information on where meetings are, what's needed to be a part of that program. So I kind of mentioned before about the motivation and self-management part. Like I gave that example of the person waking up and using that really serious experience to make the changes in their life. Like I said, that can happen. And hopefully everybody understands that self-management part takes a lot of work, takes the right person, but there are ways of doing that, of cutting off everybody that maybe is associated in the life of that person that is not a good person to have in their life, and just kind of pulling up their bootstraps and going through their life with making that immediate change. Next slide is about communication. So this involves obviously active listening. So active listening has a number of benefits and is very important to use. So it shows that you're paying full attention, and by paying full attention to the peer client, they may be more likely to share that deeper information, fully disclose more information than somebody who wasn't using those skills and wasn't communicating that they were completely present and giving them their full attention. It also validates the feeling of the person that you're talking to. So you are listening to that person, then you are not straying away from validating them or making them aware that you understand and that you empathize with their situation. It decreases defensiveness. That's very important. Once somebody becomes defensive, typically the ears close and the mind opens of the defensive person, and they kind of get shut off, and hard to get something through if a person is very defensive. So there again, active listening is very important. It also minimizes chances of misunderstanding. So when you're using active listening and you're devoting your full attention, typically your understanding of the situation is greatly improved. It helps build trust, and it can resolve conflict. The building trust part is very important. Resolving conflict also equally as important. And it also, with cross-cultural communication, there may be a person with a different culture, a different worldview than you have, and active listening can improve that communication. And active listening always leads to improved outcomes. So active listening, very important. Communication should always kind of happen with these elements being demonstrated and being used. Anything less than this might not lead to all of these good things that happen as a result of using them. So to go into those a little bit deeper on communication, there's summarizing statements, and an example of this might be something that you're checking in with a person. You want to make sure that you've heard them correctly, so you would use this type of statement. I heard you say that your boss is always talking down to you and that you hate being humiliated in front of other workers. It makes you want to quit and find another job. Is that right? So you're summarizing what they said, and then you're asking them if you understood them correctly. So they're really knowing by a statement like that you're not only listening, but that you get the context of the meaning of what they said. Clarifying questions. So did you say that you're ready to go into treatment so that you will feel better? And that's another question. Clarifies somebody who might have included that in part of what they were discussing, but might not have been the full, the only part of the conversation. So that clarifies some understanding and a good communication tool to have. Relating statements, very important for peer-to-peer, so that the person can understand, the patient, the peer client understands that the peer is also a peer and not a clinical worker, not somebody who doesn't understand where the person's been. So a statement might be after I tell my story, I always feel like I didn't do a very good job, and as a result, people are judging me for it. So that's a relating statement. And a statement of affirmation, very important. It took a lot of guts to admit you needed help. Statements like that really empower persons. It really shows that you care, that you are validating them, that you're not looking at what they've done as just another day or another decision. Really helps to improve that alliance, that rapport. So that's a really good statement to start off with. That's not a bad way to go in the first 5 minutes or so of meeting with somebody. So motivational interviewing. A lot of what we've learned so far involves a lot of these techniques. I wanted to go through some of these and talk about them. The important thing, the very first slide, this book, Motivational Interviewing by Miller and Rolenick from 1991, titled Motivational Interviewing, is very good. If you don't have the book, I would really highly recommend getting this book. It really, when I read it, it really changed the way I interacted with clients. It helped me know that a client is much more likely to do something that they hear coming out of their mouth rather than coming out of my mouth. I don't know if that makes sense, but somebody is much more likely to do something that they hear themselves say than being kind of directed by someone else to say. And there's a number of ways to go about doing that. So as you look in the boxes, you'll see there's a lot of similarities between that and peer support techniques. You have express empathy, rolling with resistance, reflective statements, supporting self-efficacy, open-ended questions, summarizing affirmations, and eliciting change talk. So reflective statements we looked at on the previous slide, but a reflective statement may be something like, sounds like if you stopped using, you'd have to give up your friends. That's a good summary of a reflective statement. What you do want to do in the rolling with resistance is pause before discussing, listen to the problems and the fears, listen for a person's insights and ideas and collaborate. Those are the things to do. What you don't want to do is to pressure, fix, or control the person. You don't want to use any kind of scare tactics. You don't want to neglect to praise persons for their efforts. And The other ones I think we've covered, but eliciting change talk is really about asking evocative questions, like bringing strong images, memories, feelings to mind, asking them to elaborate, ask for examples. The readiness roller is a really good tool to use. Readiness ruler can be used in a couple of ways, like it's a scaling question. From a scale of 1 to 10, how ready are you to enter into treatment? The person may say 6, and you can go one or two ways. You can say, what would it take for you to get to a 7 or an 8? And then they'll talk about things that they would need to build on or need to have happen. You could also go, if they said 6, you could, affirm them or give them recognition by saying, well, you didn't say 3 or 4. How come you didn't say 3 or 4? And then they would go into a strength-based disclosure about why they didn't say 3 or 4, which would typically mean what positive things have they done for them to, answer that way in their recovery. This I found was a very good quote. I happened upon it reading some NA literature. So this is from a book that NA uses for daily meditation or daily readings. Says the language of empathy uses few words. It feels more than it speaks. It doesn't preach or lecture. It listens. It can reach out and touch the spirit of another addict without a single word spoken. So that really kind of impacted me in a very, spiritual way, because I'm always thinking that it's got to be some kind of magical word said, but a lot of times your presence and the way you are with people speaks a lot louder than anything you may have to say. So just something to consider when you're working with your clients. Motivation. Motivating an individual to consider or commit to treatment. So I kind of mentioned before that I didn't want to paint a rosy picture that everybody is going to jump at the chance of coming into treatment or just going to be really enthusiastic, because that's not reality. So sooner or later you're going to come into contact with someone who wants to hold you accountable. So the second bullet point talks about assessing motivation. And if you answer yes to these 3 questions, typically you'll be motivated. And if you kind of think about this maybe in something in your own life, the can you do it basically means, do you have the tools and resources to do the thing that you want to do, to change the behavior, let's say, that you want to do. Let's maybe apply it to smoking cigarettes. You want to quit. So the assessing motivation, can you do it? Can you stop smoking by maybe using the patch or calling the hotline number or getting some Nicorette gum or something to that effect? So can you do it? And if you say, yes, I can do it, the next thing would be, will it work? Will using the patch or will using Nicorette gum or getting some counseling or calling the quit line, will that work to get you to your goal of not smoking? And the last one is really important. They're all important, but the last one says, is it worth it? Is the time and the effort and the ability to do these things, is it worth it? Is it worth it to quit smoking? And so if you think about it, if you answer yes, I have the competency, the tools, the resources to do it, will it work? Yes, the things that I said will work, and is it worth it? Yes, it is worth it. So you can kind of apply that to recovery. I wouldn't directly fire all three of these questions in a row, but you can kind of work with the client to pepper those in to find out if the answer would be yes on those three. If they can't do some, what are the barriers for not being able to do those? And how do you motivate? That's an important question to ask. So, you know, there's going to be someone who wants to hold you accountable at one point. It could be a family member, a probation officer. This is if you've been using and you're in such a bad place with your addiction that you know, you've had major loss of employment, nowhere to live, maybe homeless or whatever it may be. If you've come down and reached the bottom, there's typically someone that you're going to come in contact with that wants you to hold you accountable. And like I mentioned, it could be a family member, a probation officer, judge, employer, significant others, and they're going to talk about rules, regulations, restrictions, which I don't think is a bad thing. In my life, sometimes I need, well, not sometimes, most times I need somebody holding me accountable. But a peer specialist can inspire a person because it's coming from a different place. It isn't somebody that's wanting to hold you accountable. It's somebody coming from a place that they've been there before and they've had similar experiences. So what works, what doesn't work are some things to consider. The 4 C's of motivation: competence, choice, consequences, and community. You know, competence kind of goes along with can you do it? We all have a choice to make. There's consequences behind those choices that we make. And community talks about that we're all in this together. So motivation has a lot of facets to it. Cultural considerations can be these things: the age, beliefs, race, gender, different types of drugs of abuse, and transference and countertransference. So we need to have cultural competence, which is an awareness of your own worldview. You need to have positive attitudes towards the differences in cultures. And you need to have knowledge. Many college courses, undergrad courses have a class in cultural competency. So that talks about worldviews, cross-cultural skills. Developing cultural competence results in the ability to understand, communicate, and effectively interact with people with different cultures. So a statistic that I found on cultural is that the epidemic, the opioid epidemic, has hit nearly everyone, regardless of race. So every racial demographic has seen more overdoses since 1999. Heroin spiked, especially after 2010. Whites and Native Americans have experienced the largest rise in death rates when it comes to opioid-related facilities, and by 2014, whites and Native Americans were dying at double or triple the rates of African Americans and Latinos, and that was according to the CDC. So SAMHSA has 8 dimensions of wellness. These are important things to consider as a peer specialist interacts with a peer client. Need to look at the emotional health of the person, the environmental factors, the financial situations, the intellectual part of it, occupational, physical, medical issues they may have, their social wellness, and their spiritual wellness. So these are 8 dimensions, kind of 8 parts of the pie. You want to look at all these and consider all these when you're working with someone. So another good quote I found, from C. Jeff Miller there talks about the body and soul cannot be separated for purpose of treatment. They are one and indivisible. Sick minds must be healed as well as the sick bodies. So the WRAP is a Wellness Recovery Action Plan. That's what it stands for. The key concepts are hope, having personal responsibility, getting education, being able to do self-advocacy and support. So the other concepts are having a daily maintenance plan and those triggers, early warning signs, and when things are breaking down, a crisis plan and a post-crisis plan. So that's very important, as you can see, the WRAP plan, and that has been, was developed, I want to say, within the last 10 years and used quite effectively and is brought up frequently. There's a code of ethics for the recovery specialist, and this can be found on the Florida Certification Board. So go over these quickly: help individuals meet their needs and reach their self-determined goals, advocate for those I serve, encourage them to make their own decisions, advocate for my client's full integration into the community of his or her choice, maintain standard, proper personal conduct, and treat others always with respect and dignity, respect the person's privacy, maintain confidentiality, remain current with new knowledge about peer support and recovery, never to intimidate, harass, exert undue influence, physical force, abuse, verbal abuse, or make unwarranted promises of benefits to individuals I serve, never engage in any sexual, intimate activities with individuals I serve, never practice or condone any form of discrimination, never abuse any substances under any circumstances at any time, and never accept gifts of significant value from individuals I serve. The next slide talks about the value of using lived experience. It promotes engagement. Very important part of this is using a lived experience and helps the person move forward in their recovery. The peer specialist can have experience navigating through the multiple systems. We talked about understanding the systems, barriers to that from the peer client, and the peer specialist may have experience with doing that or knowledge. Peers, some of them have faced wrong doors and learned the skills to meet their needs so they can pass that along. These experiences are valuable. They can work with peers through the frustration and disappointment, not just handing them a referral resource list. Using a lived experience takes away the "you don't know what it's like" justification. I can't tell you how many times I've heard that doing groups or working with clients. And sharing the relapse and crisis can be opportunities for reflection and growth. So we're going to talk about teamwork in the workplace. It's important to develop a recovery culture, to use a strength-based approach. Really keep your finger on the pulse of the workplace environment. Should remain consistently person-centered, all about the person coming in for treatment, provides a welcoming, comfortable physical environment. Not helpful. What's not helpful is labeling the individuals based on a diagnostic criteria. Should not be coming, not be talking about Joe with post-traumatic stress disorder, or Joe, the person with depression. Should be using a different term than that. Should be using Joe, who has been diagnosed with depression, something to that effect. And toxic, unhealthy work environments really are not helpful. So how do we learn and work towards teamwork and workplace, a healthy one? The qualities and habits of an effective team member would have flexibility, punctuality, sharing space, answering the phone, email etiquette, gratitude, dress appropriately, and have group meetings. So the hospital program, important question is, how does this all start? Memorandum of understanding, who is responsible for what. A lot of our hospital programs had many meetings between CEOs and upper management. This did not happen a quick thing. There's a lot of liability, so there's a lot of coordination that has to be done between a hospital and a treatment provider. The peer getting access to the hospital has to have credentialing, background checks. There should be an introduction of the peer to the staff. What are they wearing? Attire is important. The staff should get education on medication-assisted treatment. There is stigma alive and well in the hospital system. So breaking down those barriers, dispelling those myths are very important. Having professional courtesy, using the proper ethics and confidentiality, knowing the system. There's typically a flow chart that really helps everybody understand what their part in the system is and which one of the staff or what staff are involved in the process of the flow chart, who's the point of contact, what roles does the ER physician, charge nurse, social workers, discharge planners have in the system. So integration of peers, there needs to be training so that the emergency department staff can understand the details of the peer specialist, help them empower both the staff and the peer, in-person trainings, research articles, workflow structures, group discussions, that kind of thing. Trainings and resources should be provided on a continual basis, particularly early stages of the program. This makes sure that some staff are on different shifts, and you want to make sure all the staff have been presented with the information. Mention flow charts, along with the agreement. Each person involved needs to know where they fit, so that there's a seamless transition between the department from the admission to perhaps the referral to a treatment program to getting to the treatment program. So kind of a simple chart of a simple example of a flow chart talks about the emergency medical. Was it an EMS that brought the person in, or did the person walk in to the ED, or were they brought in by someone? An assessment is typically made by a peer person, if they're interested or not interested in treatment. If they are, there's a release of information describing what types of information they're willing to disclose, and are they willing to give permission to share that. So with the type of treatment, do they want detox or medication-assisted treatment or some other forms of treatment? The availability of detox, getting a medication-assisted treatment appointment, and how do they get to where they're going? We're fortunate enough to have the hospital that pays for a cab to get the patient from the hospital to us. So release of information on the peer-to-peer documentation, kind of went over this. What information does the patient want to disclose? Who is it going to? What's the purpose of the disclosure? And obviously the HIPAA and the protected health care information definitely needs to be considered, and good understanding of all that the legal, parts of that need to be violations of HIPAA are very serious offenses, so we need to make sure everything's done correctly. So the data collection and follow-up. Hospitals, we have a hospital spreadsheet that talks about the information collected, talks about all interventions that are made between the peer and the peer client, the referral reason, the willingness of the person to enter treatment, referral, what were the outcomes, was there transportation, insurance, phone number, so we can do a result of a follow-up call, was the person seen for opioids, and that type of thing. I do have some statistics that just came in yesterday from our research department at Operation PAR, just to kind of help you understand how many patients are seen by our peer workers. At St. Anthony's Hospital in the year 2020, this year, 444 persons were screened by our peer. 78 of those were referred to Operation PAR, and that was this year from January to December. There was like 2 or 3 months due to COVID that we weren't going into the hospital, so those are pretty large numbers considering that's really only 9 months of the year. There's a lot of people there that were screened that were not referred to PAR. Many of those were referred to mental health providers, local other treatment providers, Turning Point, different places. They were referred to Alcoholics Anonymous, Narcotics Anonymous. Some people weren't interested at all in treatment, so but there was a large amount, 444, and 78 of those were referred to PAR. We just started in August of this year working in Lee Memorial Hospital in Fort Myers, and in that hospital, 258 people were screened, and 17 of those were referred to PAR. So that was only a partial year, August to December, and I might mention that both of these hospitals only have one peer worker. So that's a lot of work for our peer workers meeting with that many people. I just wanted to point that out. That's when we can, when I'm talking about hospital spreadsheets, wanted to give that information. So all the interventions, I went over that point. So when it comes to medication-assisted treatment, data collection, the opioid withdrawal scale, clinical opioid withdrawal scale is the COWS. Was there medication-assisted treatment used in the hospital, typically buprenorphine? Did the person have a history of medication-assisted treatment? Numbers and totals, what's the purpose of the data, what's done with it? Why have a peer? You can see that it works in retaining people in mental health and substance use services. It supports individuals playing a role in treatment through empowerment, and it lowers rehospitalization rates, and it does reduce crisis and emergency room services. I kind of went over that statistics, which kind of underlines the effectiveness of peers. So you can see that there's a bunch of health and well-being outcomes. There's, a lot of reported decreases in substance use, improved recovery, capital, like housing stability, self-care. Research also points to an increased likelihood of abstinence exposed to the peer support workers. So individual and group supervision for the peer, very important that the peer gets ongoing supervision so that they can kind of stay on top. They really need to have a place where they can talk about things that are going, that they are experiencing, kind of the secondary trauma. They need to discuss, clients that they're working with, any kind of technical issues they may be having, that kind of thing. So also it helps them know that they're not alone. They can get hours for other types of certifications. We can look for ways to improve. and know that the peers on the front line said who better to share ways of improving, introduces new ideas, innovative ideas to serve the client better. There are peer support groups that they share with others. Our organization has a group that consists of only peers, and they just have a format to talk about the challenges and the things that they're personally experiencing as they do their work. There is a case study and initial approaches. These are kind of things to consider. Like I mentioned before, each one is unique. They might have a family or a friend there for support. Somebody might be resistant to treatment. They might be ambivalent towards treatment. They might have the attitude of they've been there, they've done that, or they've been doing good and they had a recent relapse. Then they may be angry, combative, or agitated. They may not want you not to get really past the threshold. So kind of important to understand those different possible attitudes. So harm reduction model is very important. You probably heard this term. Medication-assisted treatment is harm reduction. It kind of understands that the level of use and abuse of substances is inevitable. What it does is it just wants to reduce the adverse consequences. Of course, abstinence is the goal, but harm reduction, if a person is using heroin intravenously behind a dumpster and comes into medication-assisted treatment and is now only using marijuana and occasionally cocaine, well, there's been some benefit there. The person is no longer using needles, potentially spreading infectious disease, and has improved the quality of their life. So you can understand that in the 1980s, there was this recognition. The way things were done was abstinence-only treatment. And if somebody wanted to reduce their use but wasn't ready for abstinence, there really was nowhere for them to go. So it wasn't a realistic goal at that time. And so harm reduction, a lot of times you hear that associated with needle exchange programs, that sort of things. And it reduces morbidity, mortality, and risky health behaviors. As I mentioned, needle exchange programs, decreases in HIV, all those types of benefits by using the harm reduction model. So the ROSC model of treatment, recovery-oriented systems of care, is something we hear about quite a bit. It's networks of organization, agencies, community members that coordinate a wide spectrum of services. So we have an acute care model, and the acute care model is decision-making that's dominated by the professional, talks about a short-term service relationship. The expectation is a complete resolution of the problem after treatment, and services delivered in a uniform services, often consisting of screening. So a person will come in, screen, admission, initial assessment, treatment, discharge, termination of services, uniform. And reentry, if they come back into treatment, is interpreted as a failure on the part of the individual. And that's rather than looking at the inadequate treatment design. So, step by step, the expectation is when the person leaves, they're all better, and that's typically not a reality. There are acute care models that need to be done that way, and there's a lot of funding shortages in Florida that kind of make long-term programs not too available. So working with other professionals, we need to use boundaries, respect, ethics, and look at our scope of practice. Basically, stay in your own lane. So where are we going from here in the peer position? You know, there is a lot of opportunities for peers. In many cases, like the private sector, working in those, they offer higher wages and more room for upward mobility, upward job mobility. So you can start off as an entry-level peer support, move into an advanced level peer support, supervisory position, administrative, management. There has been a discussion for years about establishing a national certification for peers, and most of us thought it would be accomplished by a peer-run organization, but as this time, nobody has stepped up to meet that challenge. That was by SAMHSA. So improving the quality of life, you know, explaining the disease model of addiction, offering health education, community resources, recognizing there's no one path to recovery, planting a seed of recovery, and believe in the ability to recover. So in conclusion, the initial steps of getting an individual with opioid use disorder into medication-assisted treatment, they do have many challenges. But if we work in a coordinated effort between organizations, treatment providers, the peers are uniquely qualified and they can add this missing piece to the current system. The peer position can be a vital factor in getting the suffering person into treatment for a healthier lifestyle. I've been to a lot of conferences, and I really have to tell you that the movement of peers and the integration of peers is really strong. There's a lot of, one thing that's needed is a little bit more research on the value, but there is definitely some promising numbers that have already come out, but this is really important, and I really hope you got something out of this. There's really a lot of benefit from this. And if there's any questions, I'll field any questions. Not sure if we have much time, but I am open to that.
Yes, we have a question, Michael. Have you encountered obstacles to hiring peers due to level 2 background checks? And if so, what have you done to work around it?
Great question. We have had those obstacles. I don't know if they have appealed to the Florida Certification Board or have found some kind of way around it. From what I understand is there usually is a time period that the person has to wait before they can be approved. There are DCF exceptions. It's a tough question. I really don't know the details of why the level 2 background check was denied, but I would appeal to the Florida Certification Board or whoever is working at the organization that the person's working at to try to address that. I'm sorry, I didn't have...
I think there was a comment. Yes, appeals, exemption process, or waiting it out are things we do to help with background checks. And other than that, it looks like you've covered so much information that it appears that you've answered pretty much any questions that people may have had. I don't see any other questions on the board. So at this time, I'd just like to thank you for presenting today and for all of your knowledge that you shared with us. And if the attendees could hold on a moment, we're going to run through a couple of housekeeping items. When we conclude today's webinar, your browser is going to take you to an evaluation on our website. If you want to receive CE credits or a statement of credit, please remember to complete the evaluation. You will be prompted to register or sign in to complete the evaluation, and you can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, please remember that you need to include your license prefix and number for the first time that you register. After you register or sign in, you'll be directed onward to the evaluation, and you will want to use the same email address to do the evaluation as when you registered for the webinar. This helps us connect your attendance and your profile. You'll also get a second opportunity to complete the evaluation through a follow-up email that will appear as soon as the webinar is over. You should get that in your email box, and it'll be from Messenger at WebEx. And remember, the evaluation closes on midnight on Friday, December the 18th. We do not issue statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. And you can find your statement of credit under Manage Profile and Content and Features and Professional Development. And just remember that it does take up to 30 days after the evaluation closes for your credits to appear. And with that being said, we'd like to thank you again, Michael, and we'd also like to thank the audience for participating in today's webinar. And lastly, we'd like to thank and recognize the Office of the State Courts Administrator for funding today's education. Have a great rest of your day, and please hold for the evaluation.
Thanks so much, Karina. My pleasure for doing this.
Thank you.